You've been told to stay on top of your health after 60. Get your annual physical, run the standard blood panel, do the tests your doctor orders without question. That's just responsible aging, right? You're doing everything your physician recommends, so you should feel protected. Wrong. I have sat across from patients, 67, 71, 74 years old, who checked every box. Annual physicals done, labs reviewed, and they still ended up in my operating room with advanced cardiovascular disease that a simple conversation could have prevented. Not because their doctors were negligent, because nobody told them that some of the most routinely ordered checkups after 60 don't just fail to help, they can send you down a medical path that causes more harm than the condition they were meant to catch. My name is Dr. Jennifer Ashton. I'm a cardiothoracic surgeon with over 20 years of experience operating on and advocating for senior cardiovascular patients. Today I'm going to walk you through 5 medical checkups that I personally would never get after 60. And the specific reasons why each one may be doing you more harm than good. By the end of this video, you will know exactly what to ask your doctor at your next appointment, and you can start preparing those questions tonight. Because the goal was never just longer life. It was a life where you're still sharp, still independent, still genuinely living, not just managing diagnoses. Before I give you the list, I need you to understand why this is happening to an entire generation of seniors right now. Because without this, the list won't make sense. Think of it like this. Every car manufacturer produces a standard maintenance checklist. Oil change every 3,000 miles. Tire rotation every 6,000. Brake inspection annually. That checklist was designed for the average car, driven by the average person, under average conditions. Now imagine you own a vintage 1960s vehicle, a classic, well-maintained but built differently. The same checklist, followed to the letter, might call for fluids, procedures, and parts that actually damage an older engine. Not because the checklist is wrong for most cars, because it was never designed for yours. Your body after 60 works the same way. The medical screening guidelines that your doctor follows were largely built on population studies. And here is the critical detail that almost nobody tells you. Those studies were skewed heavily toward younger adults. The risk-benefit calculation embedded in those guidelines, the calculation that decides whether a test helps you or harms you, shifts dramatically once you cross 60. Sometimes it shifts in your favor, and sometimes, for certain tests, it shifts against you in ways that nobody in that exam room is stopping to discuss. I have reviewed the charts of patients who did everything right, every scheduled test, every follow-up, and still ended up facing procedures, medications, and months of anxiety that originated not from their disease, but from their screening. That is not a flaw in individual physicians. That is a flaw in a system that was never fully calibrated for the informed patient over 60. So let's go through exactly which checkups fall into this category, starting with one that almost every senior over 60 gets without a second thought. This one surprises even my colleagues when I bring it up at conferences. The routine annual EKG. An electrocardiogram, which is simply a recording of the electrical activity of your heart, printed out as a series of waves on a graph. It takes about 5 minutes. It feels completely harmless. And for many seniors, it has become as automatic as a blood pressure reading at the start of every appointment. Here is the problem. When you are asymptomatic, meaning you have no chest pain, no shortness of breath, no palpitations, no dizziness, a routine resting EKG has a well-documented tendency to return minor abnormalities. Small irregularities in the waveform. Variations that look unusual on paper but are clinically insignificant, meaning they are not causing you any harm, they are not a sign of disease, and they do not require any action. But they get flagged. And once they are flagged, the cascade begins. That flag leads to a follow-up stress test. The stress test leads to imaging. The imaging leads to a cardiology referral. The referral leads to more tests. And somewhere in that chain, a procedure gets recommended that carries its own real and measurable risks. All of it started by a 5-minute test that found something that was never going to hurt you. The U.S. Preventive Services Task Force, the USPSTF, which is the gold standard body for evidence-based screening recommendations in this country, explicitly recommends against routine EKG screening in low-risk, asymptomatic adults. That recommendation exists because the evidence of downstream harm from false positives outweighs the evidence of benefit in people who feel fine and have no cardiac risk factors driving the test. I want to be absolutely clear about something before we move on. If you have symptoms, chest tightness, palpitations, unexplained fatigue, shortness of breath, an EKG is not only appropriate, it is essential. Get it. This applies specifically and only to routine screening in people who feel well and have no specific reason for the test beyond it's on the annual list. And if a routine EKG can start a cascade you didn't need, wait until you hear what happens with the next one, which involves radiation. Stress tests feel reassuring. They feel like you're being thorough. That feeling is exactly what makes this one dangerous. Cardiac stress testing, whether exercise based on a treadmill or pharmacological, meaning a drug is used to artificially stress the heart when physical exercise isn't possible, is designed to detect blockages in the coronary arteries, the blood vessels that supply the heart muscle itself. In the right patient, with the right symptoms, it is a valuable and sometimes life-saving diagnostic tool. Nobody is disputing that. But here is what happens when it is ordered for an asymptomatic senior without a specific clinical reason driving that decision. False positives. A false positive means the test returns an abnormal result in a patient who does not actually have the disease the test was looking for. In asymptomatic seniors, the false positive rate for cardiac stress testing is meaningful, high enough that the American College of Cardiology and the American Heart Association's own guidelines on appropriate use criteria specifically caution against stress testing in low-risk, asymptomatic populations. And a false positive on a stress test does not just get noted and filed, it triggers the next step. That next step is coronary angiography, an invasive procedure where a catheter, a thin, flexible tube, is threaded through an artery in your wrist or groin and guided up into the coronary arteries so that dye can be injected and X-ray images can be taken. This procedure carries real risks: arterial injury, bleeding, allergic reaction to contrast dye, and contrast-induced nephropathy, which is kidney damage caused by the imaging dye, a risk that increases significantly with age. You came in feeling fine. You leave having undergone an invasive cardiovascular procedure because a screening test that should never have been ordered found something that wasn't truly there. Before we go further, I want to ask you something. Has your doctor ever ordered a stress test and you weren't sure why? Weren't sure what symptom or risk factor was driving that decision? Drop your experience in the comments. I read every single one, and your story may be more common than you think. I want to be clear. If you have known coronary artery disease, a prior heart attack, or new symptoms that concern you or your doctor, stress testing is part of the conversation and should be. This is about asymptomatic screening ordered as routine, not about patients with a documented clinical reason for the test. Now we go from a test that triggers unnecessary procedures to one that exposes your body to something it absolutely does not need more of after 60. These are being advertised directly to seniors as peace of mind. I want to tell you what peace of mind can actually cost. Commercial full-body CT scans. You have likely seen them marketed. Clinics that offer whole-body imaging as a premium preventive service. No doctor's referral required, pay out of pocket, walk in healthy, walk out reassured. The pitch is intuitive. Catch something early before it becomes a problem. Who would argue with that? Here is what the science actually shows. A single full-body CT scan delivers a radiation dose to your body equivalent to hundreds of standard chest X-rays. For seniors over 60, cumulative radiation exposure from imaging carries a real and measurable increase in lifetime cancer risk. That alone warrants serious pause. But the radiation is not even the most immediate problem. The most immediate problem is what these scans find and what happens next. Full-body CT scans produce what physicians call incidentalomas. That word means exactly what it sounds like: incidental findings. Things the scan detects that were never the reason you came in. A spot on the liver, a small nodule in the lung, a shadow near the kidney. Research published in JAMA Internal Medicine and the Archives of Internal Medicine has documented that whole-body CT screening in asymptomatic adults produces incidental findings in the majority of patients scanned. and that the overwhelming majority of those findings are benign. They will never cause you harm. They will never become a problem. But they cannot be ignored once found. Protocol requires follow-up. That follow-up means more imaging, more radiation, sometimes a biopsy, and months of fear while you wait. A patient came to me after going through exactly this. Her name was Margaret. She was 68 years old, a retired teacher, felt completely well, and had seen an advertisement for a full-body scan at a private clinic. She went in with no symptoms. The scan returned 14 incidental findings. Over the next 8 months, she underwent 3 additional scans, a bronchoscopy, a procedure to examine her airways, and lived in a state of escalating dread while each finding was slowly investigated and confirmed as benign. When I finally spoke with her, she said something I have never forgotten. I wasn't sick when I walked in. I felt sick for almost a year after. I want to be clear about an important distinction. Targeted CT scans ordered by your physician for a specific clinical reason, a low-dose CT for lung cancer screening in a long-term heavy smoker, or a coronary artery calcium score for cardiovascular risk stratification, have established evidence behind them and serve a very different purpose. The concern here is specifically the commercial whole-body scan marketed directly to consumers as general prevention. The American College of Radiology has taken a formal position against it for good reason. Margaret's story is not rare. It is the statistical norm for this type of scan. And the next checkup on this list has a similarly misleading reputation for being thorough. Cancer screening sounds like it could never be a bad idea. That assumption is costing seniors years of quality of life. PSA testing, prostate-specific antigen, is a blood test used to screen for prostate cancer, and certain multi-marker cancer panel tests, now marketed directly to consumers, measure a range of tumor markers in the blood and flag elevations as potential signs of cancer. The premise sounds airtight. Catch cancer early, save lives. Here is the mechanism that makes this specific to age, and why the risk-benefit math changes profoundly after 60. Many cancers that PSA testing and broad cancer marker panels detect in older men and women are what oncologists call indolent tumors, slow-growing, biologically quiet. Given a patient's age and the tumor's growth rate, these cancers would never cause symptoms in their lifetime and would never shorten their life. They are real in the technical sense. The cells exist, the marker is elevated, but they are clinically irrelevant to that person's future. The problem is that once detected, the medical system is structured to treat them. And the treatment, biopsy, surgery, radiation, hormone therapy, carries its own serious risks. Incontinence, erectile dysfunction, cardiovascular stress from hormonal manipulation, and surgical complications. The USPSTF gives PSA screening a grade D recommendation for men over 70, meaning evidence shows more harm than benefit at the population level for that age group. The landmark prostate cancer intervention versus observation trial, known as PIVOT, found that in older men with localized prostate cancer, aggressive treatment produced no survival advantage over watchful waiting, but produced significantly more treatment-related harm. This discussion is about population-level screening initiated without an individualized risk conversation. If you have a family history of prostate cancer, prior abnormal findings, or symptoms that concern you, that conversation with your physician is not only appropriate, it is necessary. The problem is the blanket test ordered without that conversation ever taking place, in a patient whose age and biology make the downstream risks of detection outweigh the benefits. Now we come to number 5, and this is the one that makes even my most health-conscious patients pause, because it's something most seniors consider completely routine. Bone density testing is important. Repeating it on the wrong schedule is where the problem begins. A DEXA scan, dual energy X-ray absorptiometry, measures the mineral density of your bones and is used to screen for osteoporosis, the condition where bones become brittle and fracture-prone. For seniors, particularly women after menopause, this scan has real value. Nobody is questioning that. What the research questions is how often it needs to happen, and what gets set in motion when it happens too frequently. Here is the biology. For a senior with normal bone density or mildly reduced density, what physicians call osteopenia, meaning bone thinning that has not yet reached the threshold of osteoporosis, DEXA scans repeated every 1 to 2 years contribute directly to a pattern of overdiagnosis. Minor fluctuations in bone density measurements get interpreted as deterioration. That interpretation triggers a prescription. The most commonly prescribed medications are bisphosphonates, drugs like alendronate, sold under the brand name Fosamax, which work by slowing bone breakdown. In patients with established osteoporosis and high fracture risk, these medications have genuine benefit. But in low-risk patients started on them prematurely because of too frequent scanning, long-term use carries its own serious risks. Atypical femur fractures, which are unusual stress fractures that occur with minimal trauma, and osteonecrosis of the jaw, a painful and difficult-to-treat condition where the jawbone loses its blood supply. Research published in the Journal of Bone and Mineral Research has examined appropriate DEXA rescreening intervals and found that for low-risk patients, those with normal or mildly reduced baseline density, rescreening intervals of 5 to 10 years produce equivalent clinical outcomes to annual or biannual scanning, without the overdiagnosis risk. The USPSTF osteoporosis guidance incorporates the FRAX tool, a fracture risk assessment calculator, to individualize that decision rather than applying a blanket schedule. If you have established osteoporosis, a prior fragility fracture, meaning a break that occurred from a minor fall or impact that a healthy bone would have survived, or if you are already on bone-modifying therapy, your rescreening needs are genuinely different, and your physician should be making those decisions based on your full clinical picture. That is not who this applies to. 5 checkups, each one routine, each one carrying risks most seniors are never told about. Now, I want to address something you might be feeling right now. I know exactly what some of you are thinking right now. Dr. Ashton, are you telling me to skip my checkups? To stop listening to my doctor? That doesn't sound right. I hear that. And that concern is not only reasonable, it is exactly the right instinct. You should question anything that sounds like a reason to do less with your health. So let me be direct with you. That is not what this is, not even slightly. The message of everything you just heard is not fewer checkups. It is smarter checkups. It is the difference between being a passive recipient of a default medical checklist designed for the average patient and being an informed patient who understands which screenings are actually calibrated for your age, your risk profile, and your individual health history. Those are two completely different experiences, and the second one produces dramatically better outcomes. I have watched this shift happen in my own patients. When they stopped showing up to appointments ready to accept whatever was ordered and started showing up with questions, specific, informed questions, the quality of their care changed. Their physicians engaged differently. Decisions got made with more nuance, and the cascade of unnecessary testing that I described tonight stopped before it started. You are not the enemy of your doctor by asking these questions. You are a better partner. That is what being an informed patient actually means. So here is exactly what I want you to do, starting tonight, to take that informed patient power into your very next appointment. Think of this list not as a warning. Think of it as the cheat sheet your doctor never had time to hand you. First, write down the 5 checkups from this video. Not later, tonight. Put them on your phone, on a notepad, on whatever you will actually bring to your next appointment. And when you are sitting in that exam room, ask your physician one specific question. Given my individual risk profile, my age, and my health history, is each of these screenings actually appropriate for me right now, or can we talk through alternatives? Frame that as a conversation, not a challenge. You are not accusing anyone of anything. You are participating in your own care. That is how it is supposed to work. Second, ask for a personalized screening schedule, not a default one. Ask your doctor which clinical guidelines were used to recommend your current tests, and whether those guidelines were designed for patients in your specific age group and risk category. That one question alone, asked calmly and sincerely, will shift the entire dynamic of the appointment. Physicians respond well to informed patients. Most will welcome the depth of that conversation. Third, go to the USPSTF website tonight. The United States Preventive Services Task Force, USPSTF.gov, is a free, publicly available, government-supported resource that publishes evidence-based screening recommendations organized by age, sex, and risk factor. It takes 10 minutes to look up the tests that have been recommended to you and see what the independent evidence actually says. That is 10 minutes of reading that can save you months of unnecessary procedures. You do not have to do all three tonight. If all of this feels like a lot, pick the one that feels most immediate. For most people, that is the first one. Write the list, bring it to the appointment. Do that one thing, once. Then again at the next appointment. That is how real change in your healthcare actually begins. The power to be an informed patient has always been yours. Tonight, you just got the information to use it. Let me bring this all together before we close. What you learned today is this. Routine annual EKGs in asymptomatic seniors carry a real risk of triggering a cascade of follow-up testing, stress tests, imaging, invasive procedures that originated not from disease, but from a clinically insignificant finding that should never have driven that chain of events. Cardiac stress testing ordered without a specific clinical reason in low-risk, asymptomatic patients carries a meaningful false positive rate that funnels seniors toward invasive coronary procedures and their associated risks. Commercial full-body CT scans sold directly to seniors as preventive screening expose them to significant radiation and, in the majority of cases, produce a flood of incidental findings that generate months of anxiety, repeat imaging, and unnecessary biopsies before being confirmed as harmless. Broad cancer marker panels and routine PSA testing in older men, initiated without an individualized risk conversation, can lead to detection and aggressive treatment of cancers that would never have shortened your life, while the treatment itself causes serious and lasting harm. And DEXA bone density scans repeated too frequently in low-risk patients push seniors toward overdiagnosis of osteoporosis and premature use of medications that carry their own significant risks when used without established clinical need. Now I want to ask you something. Which of these 5 surprised you the most? And have you ever been sent down a path of follow-up testing that turned out to be nothing at all? Tell me in the comments. Your story is not just your own. It may be exactly what someone else watching this video tonight needs to hear to make a different decision. If you have a parent, a sibling, or a close friend over 60 who goes to every appointment and accepts every test without ever asking a question, please share this video with them tonight. Not because the medical system has failed them, because they deserve the same conversation you just had. That conversation is a gift. Pass it on. Next week, I am covering the 5 blood test results that most physicians consider completely normal for your age, but that I treat as early warning signs every single time I see them in a patient over 60. Subscribe and hit the bell so you are there when that video goes live. It has been a genuine privilege to spend this time with you. Stay curious about your health. Stay engaged in your care. And remember that the most powerful thing you can walk into any doctor's office with is not a list of symptoms. It is the right questions.